we started pediatric anesthesia, and we just started the basics, the basic problems which any anesthetist face when we are anesthetizing a pediatric or neonate. Okay, so we discuss some of the challenges in the pre-operative assessment, some of the challenges regarding IV line, regarding consent, regarding basic physiological, pharmacological, and anatomical differences we started, and we just discussed some of the aspects of respiratory system and airway. So we will continue from there. Everyone can hear me? Okay, so Hassam, we will just continue from the cardiovascular system. So what are the, just like we said that in respiratory system, because in the fetal life, the lungs have more pulmonary vascular resistance, and because lungs are filled with fluid. So with the first breath, this pulmonary vascular resistance decrease, and the flow from the pulmonary artery start going towards the lungs. So with this increase in PO2 and some effect because of prostaglandins, this ductus arteriosus, which is connecting or bypassing the flow from the right side of the heart going towards the lungs, bypass from pulmonary artery to aorta. Okay, so but with this first breath, this ductus arteriosus tends to close, and it can remain open for some hours to some days, unless there is some pathological problem in which even this PDA can remain patent, and even there will be certain conditions or congenital anomalies in which we therapeutically keep this ductus arteriosus patent. Otherwise, a patient will not be able to survive. Okay. So with this, a number of times this concept comes about preductal oxygen saturation or preductal ABG sampling when we are dealing with a patient with congenital diaphragmatic hernia or tracheoesophageal fistula. So do anyone knows what is this? What is this preductal? Can anyone explain? Because this terminology comes again and again. Hossam, can you just say a few words?
Sir, basically in these, whenever we are concerned regarding patent ductus arteriosus, we want to differentiate between the pre-ductal and post-ductal circulations. So if we are having our pulse oximeter on right radial artery or any reading before that, so we can differentiate that either there is mixing or any kind of shunting. So we can differentiate on these things.
Like the right radial artery arrives from aorta from a place which is proximal to ductus arteriosus. Okay, so yes, that will be our demarcation. So if there is residual circulation, this will, and if there is if there is residual circulation, but the shunt is from left to right, will it change anything?
No, sir.
Okay, so it will be a problem in cyanotic heart disease where there is right to left shunt. Okay, everyone clear? It will be problematic in cyanotic heart disease, where this ductus arteriosus is patent. Okay, in that case, the saturation or circulation, if you want to see before the mixing, so you will have to look at the right radial artery. Okay, so this is the thing which you will be which everyone will be facing this thing. Okay, so another point which was raised by Hussam regarding the lung compliance and chest wall compliance. Okay, so like we discussed that because of decrease in pulmonary vascular resistance, gradually pulmonary vascular resistance decrease, so lung compliance decrease if you compare it with the fetal circulation. So gradually lung compliance improves in the baby, in the newborn, as compared to the fetal counterpart. Okay, but it is still less than an adult. And what is the reason, Hassam? Why lung compliance is less as compared to adult?
So those wall-related issues, horizontal ribs and diaphragmatic.
No, your voice is breaking. It is because of decreased number of alveoli. Okay, so now number of alveoli are less, and they are relatively less compliant as compared to the adults. Okay, and even this is more pronounced in premature babies, where surfactant may be needed to give to decrease the surface tension and improve the lung compliance. Okay, so the clinical correlation for this concept is that you have to give pressure control ventilation, not only because by mistake if you give a very large volume, patient lungs can rupture, they can have barotrauma, or even because of the compliance, you need to adjust the volume according to the pressure. Okay, and the other correlation because of this decreased compliance in the lungs and the chest wall is that usually they are dependent on the rate. Okay, because this was a confusion to one person, so I just need to clarify this thing before we go on to cardiovascular system. So because the minute ventilation is increased, the oxygen consumption is more. Okay, so to counteract this thing, we need to have a high minute ventilation in the babies. So usually if you want to increase the minute ventilation, either we can increase the respiratory rate or tidal volume. But in this age group, because of the respiratory mechanics in compromised state, because of the horizontal ribs, because in adults, these ribs are relatively with the angle. So it is creating more bucket handle movement, creating more increase in tidal volume. So that mechanism is less developed in this new small kids. Okay, so the only thing which is left is the rate. So if the respiratory rate decrease, the babies are not able to maintain the minute ventilation, and they tend to become hypoxic. And because oxygen is consumed more, it is around like 6 to 8. In different books, you will find different. So roughly it is double, you can say, but you will find maybe different number in different books. So the basic concept you need to understand that it will be the oxygen consumption is more in babies because of metabolic requirement, and they are needing more oxygen. Okay, so I hope this is clear, Hassam.
Yes, sir.
Okay, so just one more thing which we did not discuss, there was the control of ventilation. Okay, usually how our ventilation is controlled, like what is the basic mechanism to control the ventilation?
Sir, hypoxic and hypercapnic drives.
And some voluntary control. It also has effect, like there are so many respiratory centers, which have some involuntary and some voluntary control, as well as they are responding either to CO2 or O2. Okay, so the main response is through CO2, and hypoxic response is relatively less pronounced as compared to CO2. Okay, so in babies, this response is not very blunt, especially if the babies are premature. So that's why they are not able to respond to hypoxia or hypercapnia in a way as an adult does. Okay, so they tend to become hypoxic or hypercapnic relatively early, especially if they. That's why we are worried about premature babies before 60 weeks of gestation, and we are not doing any day surgery, or we are expecting apnea, so we have to monitor the with the post-operative apnea alarm. Okay, so one of the reason for is that, and this one. And another thing which I always forget, do anyone knows the number of alveoli when they become equal to the adults? The maturation of alveoli? Yes, Assam.
Just saw it. It's 8 years.
Unfortunately, your voice.
I've just seen it.
Your voice is distorted. If you can write in a message.
Sir, they are fully mature by 8 years of age.
Okay, I'm not sure. So if anyone has some other number in the mind, you can just drop a message. Okay. Okay, so this is another thing. So we have to take care. You know, if you are just trying to understand through the practical implication, it will be better, and you will have more like retention as compared to if you are just reading without any reason. Okay. So this is another thing. So what about cardiovascular system? What are the? We will just continue like that. If we miss anything from the respiratory system, we can discuss later on as well. Okay. So what are the cardiovascular changes? Or what are the difference in cardiovascular system? What do we say? That they have heart rate dependent, and they have, yes, their cardiac output is dependent on the heart rate, and their stroke volume is relatively fixed. Similar is the case in some valvular heart disease, and in similar is case in the elderly, that they are relatively towards the same state, that usually whenever there is some requirement, adults can manipulate by involuntary control of this one, like their venous return will be changed there because of sympathetic activity, because of the baroreceptor reflexes. But in neonates and this young babies, they are unable to control it. Okay. So what about like how clinically it is we can correlate this thing? Relatively, they have high heart rate. And what about the sympathetic and parasympathetic control?
Sir, they have high vagal tone, and the sympathetic system is not that well matured.
Okay, so what can happen? what will be the result?
Sir, they are prone to bradycardia.
They are prone to bradycardia. Okay, so that's why if we if they are having any condition in which they can have vagal responses, that will be very blunt, that will be very brisk. Okay, so you have to take care of. That's why the traditional anesthetists tend to add atropine as a pre-medication in patients, in babies. Okay, even if they are giving, for example, ketamine, even though it is causing tachycardia itself, or it can cause tachycardia, they are also adding it for not only for atropine. Why they are adding atropine? Have you seen people adding atropine or glycopyrrolate with ketamine? What is the reason for it? Yes, what is the reason for adding glycopyrrolate or atropine with the ketamine, other than bradycardia? Yes, it is because of the secretions. Okay, so because of the, actually ketamine causes tachycardia by releasing catecholamines. Okay, so this response is relatively less in babies because they have less developed mechanism of this sympathetic system. So, but still, this is theoretical possibility. So that's why they add it. They add atropine in pre-medication. So because they are worried about the this one incidence of bradycardia, secretions as well as bradycardia. Okay, I'm not able to explain in a very nice way, but I repeat it that ketamine, it's the effect of ketamine is not very pronounced because of less developed sympathetic system. Okay, so this is one point. The other point is that when they are giving ketamine, they mix atropine or glycopyrrolate because ketamine can theoretically increase the, or it can increase the secretions. Okay, so this is another point. And you have to, what about the blood volume? How much is the blood volume? How do how you compare blood volume with the adults?
Sir, the blood volume is also increased. In units, we usually take it 80 ml per kg, where in adult male we take it as 65 ml per kg, in female 70 ml per kg.
Okay, that is even more in premature. Okay, even up to 100 ml per kg, 95 to 100 even in premature babies. Okay, so because why we should be looking at the blood volume? Why it is important to just have a look whenever we are dealing with any patient? Why we should calculate the blood volume?
Sir, to estimate the blood loss, which will cause significant changes.
Yes, you are missing one key word, that is the allowable blood loss. Sir. Okay, so for calculation of allowable blood loss, you need to know the blood volume. Okay, because maybe that few mils of blood or something, it is not significant in adults, but the same amount is too much for babies. Okay, so that is the reason. So for pediatric age group, I'm just trying to tell you, no, I'm not trying to just reproduce any book. I'm just trying to make you correlated with the clinical aspects. So that's the reason for this is I have told. Okay, so you have to calculate how do we calculate the blood loss? What are the different ways?
Sir, the allowable blood loss?
No, allowable blood loss, that is through the blood volume and then initial hematocrit and then the allowable hematocrit and then we calculate it. That is a formula. I'm not telling this. How to assess the blood loss, what you should have in your mind.
Sir, how we, your basic question is that how we assess blood bleeding in surgery?
Yes.
Sir, there are various methods. One of them is gauze count. We can have an estimate regarding that how much chest gauze are drained, how much abdominal sponges are drained, and then we can weight them.
What is the exact method? It is to weigh before and after. Immediately, not after 1 hour, because a number of things will be evaporated. So, and another thing is that there should be standard gauze, because maybe different companies, different material will soak different amount of blood. Okay, and the color, how much it is fully soaked or it is less, because in adults maybe it will have less effect relatively, but in babies it will be a significant effect. Okay, so you should be knowing your one thing is the gauze and the weighing. Then what else? Drain.
Sir, changes in hemodynamic parameters.
Yes, that's what I wanted to listen. The changes in hemodynamic parameters is less pronounced in pediatrics. They are already tachycardic. What is the usual response of hypovolemia?
Tachycardia.
So they are already tachycardic. So this hypotension and tachycardic response because of impaired baroreceptor function, it's not pronounced as much it is in adults. Okay. And another thing, I tell you something, just I am asking you that if you are using any medication, like for example, you are using Dex Meditomidine and you have a patient with bleeding, will it have similar effect?
No, sir.
Okay. So that's why the numbers can deceive you. If you are having a bleeding patient, and by the way, you are using Dex Meditomidine, so though you have to be very careful because the effect will be different. And during anesthesia, there can be different response. So you have to see the overall clinical picture. That's why whenever someone is asking you, clinical parameters are one of them, the generalized picture of the patient, because that's why it is difficult sometimes to assess the bleeding during anesthesia. The patients, if they are awake, maybe there will be some psychological changes. Okay, if anesthetized, of course you are not able to do that. If the patient is exposed, you will be able to see the skin, mucous membranes. In anesthetized patient, maybe you will not be able to pick in the way you are doing it any other patient. Okay, so these are the things, the clinical parameters. Then the hemodynamic response will be a little different as we are discussing the babies, so it will be a little different as compared to this one, like adults. So just you have to keep this thing in your mind, because we say this word but we are not able to interpret what is the significance of this point. Okay, so that's why we are expecting bradycardia. We are taking care of the estimation of the blood loss. Okay, and we are thinking that the sympathetic system is not very active. Okay, and because the heart is depending on its contractility. So if there is anything which is depressing the cardiac contractility, because there are the other mechanism are not very like functioning as compared to adults. So you have to consider these things. That's why if you are replacing blood in pediatric patient, in adults you will be able to say, oh, you have given 1 unit of blood or 2 unit of blood, so now please add calcium. How will you calculate in pediatrics? So you have to be very careful. You have to do serial ABGs, so to see the ionized calcium. So if it is going towards the lower side, you have to replace early. Okay, and related to just ionized calcium, which is better, calcium chloride or calcium gluconate? How many of you have used calcium chloride?
So usually calcium gluconate is used, but I've read somewhere that calcium chloride gives more calcium.
It gives 3 times. It gives 3 times more. It gives 3 times more ionized calcium. And actually it is better to because you people are not familiar with it, so you are afraid. Calcium chloride is better. Okay, calcium gluconate is not at all a very good choice. Calcium chloride is a better one, but because generally it's not available, people are afraid. Yes, you have to give it slowly, but calcium chloride is a better choice. Okay, so this is another point I just wanted to clarify. Why calcium is important? Why we are worried about calcium? And why we are worried about potassium? Yes, you know, all other people, if they are shy, don't want to speak out, they can still they can write a message. Otherwise, I will be very happy if all people give some input, raise the hand, don't shy. I don't have any stick by which I can hit you, so don't worry about it. Okay, Sam, if you are telling, please, what is the problem with calcium or potassium?
Sir, calcium is very important as it is maintaining the contractility of heart. And potassium is the major intracellular ion.
Like, you know,
So,
you can have a simple answer that if for the action potential, because heart has to contract constantly, am I right? If there is anything which is disturbing the action potential, it can have detrimental effect. Okay, so for the contractility and have the inotropic effect and chronotropic effect, you need to have the adequate calcium. Okay, so otherwise heart contractility will be depressed. And similar is true with the potassium, that if potassium level increase significantly, it will have a detrimental effect. Okay, and here where there are more compensatory mechanism there, they will maybe tolerating it more. But if it is a baby, or if it is an old age, or any patient with compromised circulation, he or she will not be able to compensate for it. Okay, so that is the basic concept about it. So if someone asks you, you have to tell in a conceptual way. You will not forget. If you are just cramming a paper, a page of book, you will forget. But if you have a concept why you are doing this, why it is important, then you will like why phosphate is important. I'm just giving you a basic why phosphate is important. What is the basic reason? Phosphate. We discuss a lot about calcium and potassium. What is the problem, or what is the need of phosphate?
the phosphate is an important buffer.
Okay, is it related to buffer? Which is the most important buffer in our body?
Bicarb.
Usually. Okay, so maybe it is not the reason. All of the cells use what for their activity?
Sodium, potassium, ATPase pump.
ATPase pump. So what is required?
Phosphate, sir.
Okay, so it is the fuel. If there is no phosphate, there is no ATP production. So phosphate, that is so important. Okay, so phosphate, whenever there is lack of phosphate, that's why in ICU it's one of the killer. Phosphate level, if it is not maintained, it is one of the major cause of failure to be weaned off. And we never, because it's not available in any of ABGs, So we are not thinking about it. Okay. So that's just a message to you, because we just discussed about calcium and potassium. So calcium, potassium, magnesium, everyone talks. Why? What's the problem with sodium? Sodium significance more in cardiovascular system or something else? Like calcium, potassium is more related to heart. Okay. Phosphate, we say it is related to any cell. Okay. So what is the main selling point for sodium?
CNS.
CNS. Okay. So our neurological system is dependent on sodium level. That's why whenever there is neurological injury, there are changes of mechanism which are controlling the sodium balance. So it is related to ADH, it is related to aldosterone. Like patient can have problems related to ADH, or patient will have any problem related to aldosterone. The kidneys are not able to conserve sodium, so they tend to lose, so they tend to become hyponatremic. And what sort of mentality we had before, that we used to give a solution like replacement fluid, which is terrible for the babies. Okay. Its name should be PEDS killing solution rather than PEDS solution. Okay. And it's a pity that still people are using PEDS solution in many part of world. Okay. So like that is the concept we just passed, we just peeped through a window. Okay. And the people who are at the moment here and not getting a very attractive any attraction, because we are not discussing any MCQ. Am I right? So they will be whispering, oh, we are not discussing any MCQ. So what is the purpose? Because we are, Dr. Zishan, we are preparing for IMM. So we have to practice MCQs. So whatever I am discussing will be giving you some knowledge for MCQs. Am I right? Will be giving you some insight into the knowledge, the real knowledge, which will remain in you, inside you more. Okay. So please just have mercy on yourself, and the people who are only thinking that because they are preparing for IMM, so they are only interested in MCQs, or even FCPS people, they are not interested in understanding the thing. They are just trying to get their pool of MCQs, so that they are able to prepare it. Okay. And they will pass the MCQs part of the written part of FCPS, and then they will have very beautiful time preparing for Viva. Okay. Dr. Ahmeduddin Sumrup, if you can close your camera, please. Okay, thank you. Okay. So we will move on. What about any other thing which we need to talk about circulatory system, CVS? Yes, any one of you? Okay. So you should be knowing about the blood. What about the blood pressure? How much is the blood pressure as compared to adults? How much is the blood pressure in newborn? Usually, how much it is and how it increase?
Sir, usually at the time of birth, it is somewhere around 60-40, 65-40.
We should be talking about mean. Okay. Sir. Mean ranges.
Sir.
Okay, you can talk about systolic as well.
Around 50.
Okay. Okay, your voice was distorted, but around say up till which age they will have the adult blood pressure?
Sir, after 3 years.
After 3 years or slightly more? Just confirm it, because this will also be written in different books differently. I think 5 to 6 years or something like that. You just reconfirm it. I think it will not be 3 years. Okay, it will be slightly.
Sir, where I have studied it is they have given values 170 at 3 years and 110/70 at 12 years.
Yes, so that's what I was saying. That usually it will be around 10 years or 8 years, I think, when it will be nearer to the adult range. Okay.
Yes.
So that is one more thing which we need to see. That's why, because that will be the problem with the interpretation. Okay. So blood pressure, remember that blood pressure, heart rate will not be a very good sign of change hemodynamic blood volume. So you have to be very meticulous in looking at the blood loss and respond accordingly. Okay. So this was the message. So what about the renal system? And what will be the interpretation? One of them thing we have already told, that they are not able to preserve the sodium. Okay. So they can lose sodium and become dehydrated. They are not able, they don't have the very good concentrating ability. Okay. And what about the urine output? How much you should be maintaining? In young babies, usually we say around 1 ml. In adults, so it is no, it is more than that, Hassan. It should be around 2. Okay, if we just use the word 1 for adults, we have to say 2 for pediatrics. Okay, and there usually their function of nephron mature by 2 years of age. Okay, this is one interpretation, that you have to look at the urine output. You have to consider patient having dehydration. That's why we have to give some people, majority people, they are afraid of giving fluids. Okay, but you have to maintain the fluid volume, because they can become dehydrated very easily. So yes, of course, you don't have to give fluid without calculation, but you don't have to give less fluid, because it will also have detrimental effect. You have to maintain it. Okay, so at this point, we can discuss the fluid as well. So usually everyone knows about this formula of 4-to-1. Okay, so for first 10 kg, this is for maintenance. Okay, maintenance. So it is Holiday and Cigar formula, 4 ml per kg for first 10 kg. Then from 11 to 20, it is 2 ml per kg. And for the rest of the weight, it is 1 ml per kg. So for example, if it is 15 kg baby, so it will have for first 10 kg, 10 multiplied by 4, it will be 40. Okay. And for the next 5, it will be 5 multiplied by 2, 10. So it will be 50 ml per hour. It is a maintenance. So, so one thing is maintenance. What else other fluids we have to calculate? Anyone?
Sir, the NPO and the losses.
NPO losses, and what else? Very good. Insensible. Okay. So we have to calculate the deficit because of NPO or any ongoing losses before that, like patient can have diarrhea, patient can have vomiting. So you have to consider that thing. So deficit is one thing, maintenance is second thing. Insensible loss. What about insensible loss? How this is an insensible loss occurs. And especially during the mechanical ventilation, because we are not using the warm gases. Okay. So evaporatory loss is like around 4 to 5 ml per kg, if I'm not wrong. Okay. This is evaporatory loss, and then third spacing. Third spacing is according to the surgery. If it is a superficial surgery, it will have around 1 ml per kg. Okay. If it is intermediate surgery, it will be 3 to 5. And if it is like open body cavities, like for example, laparotomy, so it can have around 5 to 8 ml per kg per hour. So you have to calculate the third spacing accordingly. And if any drain is there, you have to look into it. And then you will monitor it through urine output as well. If you want to see that if you are giving fluid, or in any scenario, if the urine output is maintaining, exceptions will be any neurological injury in which the control of urinary control or like mechanism is impaired in any condition like ADH, or if you have given any medication, like for example, if you have given mannitol, so things will be different. You have to consider that thing in your mind. Okay. So otherwise you will just calculate deficit, maintenance, third spacing, insensible, and any other ongoing losses. Regarding the blood and blood products, you will be considering that according to the allowable blood loss, that allowable, like for example, you calculate that 100 ml was allowable blood loss. Okay. And patient bled 100 ml, for example. So you have to replace it, but that allowable blood loss you can replace either with the equal volume of colloids or blood. Okay. You can give, still you can give, for example, if it was allowable blood loss, you can still give blood. Okay. Or colloid in equal volume. And if you don't want to give any colloid or blood, you will have to give 3 to 4 times of crystallite. Like for example, if it was 100, so you have to give either 100 ml of blood, 100 ml of colloid, any colloid, or 300 to 400 ml of crystallite. So this is the concept related to blood loss. And then isotonic fluid loss, any, for example, you put NG tube and there is a lot NG secretion is coming, or any other drain patient can have chest drain and then there is some fluid coming. So you have to, that will be isotonic, and you can replace it with the crystallites. And then this one deficit, usually you will calculate it. For example, if it is 10 hours NPO and you calculate 50 ml for 15 kg, so 50 multiplied by 10, it will be 500 ml. And so usually you don't give it in the first hour. If it is 3 to 4 hour surgery, you can divide it and gradually you can replace it. Or if it is 1 to 2 hour surgery, you can give half of the deficit in the first hour and half replacing the other half in the later part. But remember one thing, this is just a mere calculation. Better answer is to see the hemodynamic response, fluid responsiveness, and you can use the word goal directed fluid therapy. Okay, that you are giving some fluid and then you are getting the result, and then you can, this is not you can say that you have to do it at any cost. It's not like that. You have to be meticulous, and you have to decide or calculate according different in different situation. Okay, so this is whatever we are talking is perioperative. Okay, so someone just wrote in message box post-operative fluids. It's a similar. Of course, when the abdomen is closed, after that, that third spacing will be gone. You have already replaced the deficit. So you only have to continue with the ongoing loss and the maintenance. Am I right? Understand? Hassan or Hassan, or whosoever you are. Dextrose, actually this one we discussed in later part of our last discussion. Why you want to give dextrose? Can you speak out, please? Why you want to give dextrose? What do you think that adults doesn't need energy? Why you are only interested in giving in pediatrics? There is a reason for it. Can you speak out, Hassan? Anyone?
Sir, for
Yes.
Because in adults maybe the fat reserves are better and
Fat,
they can
fat or
prolong.
something else?
Sir, that
What we convert?
sir, glycogen
Glycogen.
reserves are
Glycogen. Okay, so glycogen reserves are better. So there is less chances of patient going in hypoglycemia. Okay. And in pediatrics, because of this less control of glucose, they are glucose loser. They are not able to control the blood glucose as in adults. That's why you are what. So you can monitor it through the through blood glucose. Okay, you can monitor the blood glucose. You can do ABGs. Okay, and then another thing is that another concept is that in replacement fluid, like you can say the deficit, it's better to give isotonic fluids, and the maintenance fluid can be dextrose half normal saline. Okay, dextrose saline. This is one concept. Or you can give isotonic fluid and you can give dextrose separately according to the blood sugar. Like there maybe you have a premature baby who is expected to become hypoglycemic. So the things will be different for that baby. Okay, and you have a normal baby which is no other comorbidity. You can give it with the half dextrose saline. Okay, you don't need to give 10% in every patient. You don't need to give 5% separately in every patient. Still, you need some sodium as well. So, but you can give half a dextrose normal saline, like this 5% dextrose water with 0.45% normal saline, half normal saline, and that you can use for maintenance. Okay. For the replacement and deficit, it is better to give isotonic, that Ringer's lactate, or non-lactated solution like plasma light. Okay, it should have the electrolytes similar to the plasma. That is the basic rule. Okay, so anything else about this fluid? We discussed almost every aspect of it: how to assess, how to calculate, how to replace. Okay, any query, any question about it, just ask. If anything you don't understand, please do ask before we move forward. Don't feel shy, okay? Okay. So this is also related to the things which we were discussing about fluid is also related to liver and kidneys and heart status. Okay, you cannot give too much fluid to start with because heart will not be able to accommodate it. So it is better to go in a way that you are doing it according to the goals. Okay, and fluid responsiveness. And regarding the liver, because liver is immature, so what will be the effect? What about the drug metabolism? So drug metabolism will be slowed down. Okay, and because of high blood volume, so maybe initial doses requirement will be more, but gradually because of slow metabolism and slow excretion through kidneys, you need to optimize the maintenance doses. Okay, so this is the concept about it. One thing I missed in the circulation is related to, like, we can discuss about hematology. What about this hemoglobin F? There is difference in hemoglobin F and hemoglobin A1 and A2, which is more in adult. So gradually it like its level decreases. Okay, and the difference is that hemoglobin F will have more binding of oxygen, and less tissue delivery. So like you can say that it has left-sided left-sided dissociation of the oxygen hemoglobin, left-sided shift of the oxygen hemoglobin dissociation curve. Okay, so this is one thing you can exactly recall what is the alignment of the chains, because there is, I don't recall, there is some difference in the alignment of the chains, the amino acid chains between hemoglobin A, A1, A2, and hemoglobin in hemoglobin F. It is a little bit different. Okay, so this is one thing. And what is the concept of this physiological anemia? Why it happens? Yes, do you know, anyone knows about it? Why the
Sir, there's
yes, please.
slow fall in HbF at the age of 2 to 3 months, and there is an increase in HbA, adult hemoglobin. At that level, there is a physiological anemia.
Okay, this is one reason. This may be one reason. I'm not sure about it. I cannot deny it. But actually, this conversion is not the reason for anemia alone, because there is how this blood volume is maintained. One thing is plasma, and one thing is RBCs. Okay.
RBC.
So RBCs volume is relatively decreased. So this is decreasing the concentration. Like volume is more increased as compared to RBC volume. So there is a decrease in it, decrease in the concentration. Okay.
Infants have more blood volume than adults.
Yes. No, you are right. Like I'm telling about that gradually this volume is decreased. Am I right?
Okay.
Gradually it is decreasing, but the composition gradually decreases in a way that RBC volume is not maintained in the same value. So the concentration decrease. So this is related to hematopoiesis, and it is compensated by the age of around 1 year, I think. Like if you find a baby around 6 months, around 6 months, this effect will be pronounced. Okay.
Okay.
And what about why we are, in every baby who is born, we are giving vitamin K. Why we are giving it?
There is a concept due to liver immaturity. There is
Okay.
deficiency in vitamin K dependent clotting factors. So to prevent intracranial hemorrhages, we have to give, I think.
Yes. Vitamin K dependent factors, what are those? Just for revision.
Sir, 2, 7, 9, 10.
2, 7, 9, 10. And there is also like platelet function is not very developed. Okay. Vascular endothelial function is not very much developed. So this combining it, and so that's why we are replacing vitamin K, and with after some time vitamin K control of this clotting factors is maintained by the babies later on. Okay. And another thing is that because we have to maintain the blood volume, so usually the transfusion triggers will be they are almost the same, but you need to be very careful, and you have to replace early. Okay, because they will not give you time. So what else? We already discussed about maintaining the temperature. Okay, so because they don't have the shivering mechanism to produce the heat, and what they use for the maintenance of temperature, what is that thing? That is called as non-shivering thermogenesis. So from where it occurs? Non-shivering thermogenesis. Because of what we called it? That is brown fat. Okay, so brown fat, it is present in which part? It is around scapula, mainly some bones, around bones, mediastinum. Okay, so this is the, so that's why we have to expect that the babies can become hypothermic. We have discussed this thing, how to control it by giving warm fluids, by blanket, warming blanket, and then giving warm humidified gases and bear hugger. Okay, but we don't need to cook the babies. So we have to maintain it, we have to control the temperature, but at the same time, we should be thinking that it can cause burns as well if we are overcooking the babies. Okay. By the way, what are different ways to lose heat? Can anyone tell?
So this is radiation,
Yes.
evaporation,
Yes.
convection, and
Okay.
fourth,
Conduction. Direct
convection.
we touch. Radiation is through the, like the gases which are near the body, they get heat, and it is replaced by the other gas which is cooler one. So that's how radiation occurs. Evaporation, everyone knows, because of the cooling effect, the loss of the vapors. Okay, and conduction.
It's from one body to other body.
Yes,
It's
by
like
the direct touch or transfer of the heat. Okay, the thing which I have told is, I think it is convection, not radiation. I'm just myself confused. What is difference between radiation and convection? Anyone can explain?
convection is heat loss due to movement of air around the.
Yes. So that's what I told. So that was convection, not radiation, by mistake. Apology for that. The thing which I told, the air in near the body gets the heat, and it is replaced by the other gas which is of lower temperature, and that's how heat is lost. Radiation is that every body is radiating heat. I'm not sure about. Maybe I'm not able to explain it in a very nice way, but that is the major. If you came across this question in MCQ, the mostly is through radiation. Okay, mostly heat loss is through radiation. Remember this thing. I just wanted to tell you this thing. Okay, so what about nervous system? What about MAC? MAC requirement is low or high? In the in the neonates, MAC is low. Okay, and in the relatively elder babies, the MAC is increased. MAC is increased. Yes, MAC is increased. Okay, and blood-brain barrier. What is blood-brain barrier will be poorly formed. Okay. So anything else I have left with? If everyone knows about fasting. Okay, so it is 2 hours for clear. We discussed last time as well. 2 hours for the clear, 4 hours for breast milk, and 6 hours for formula milk, and 8 hours actually for the Pakistani food, and 6 hours for the Western food. Fatty meal, it is 8 hours. Okay, so usually our Pakistani Indian food, it should be 8 hours actually, rather than 6 hours. Okay, so some words about, we have discussed some of the concept of this sedation, pre-medication, anxiolysis. If anyone wants to discuss that thing, you can just review the first part. Okay, so we will just move from there. In next session, we will go towards any disease Any question up till now? Anyone wants to want to ask any question? Okay, so for any patient, any age group, there will be some logistic issues related to monitoring, relating to equipment, relating to bringing the patient inside the OR, and from there on you can move on. So similar, we started that whatever we are studying, just try to correlate with the steps of anesthesia which we do. Like we started from pre-operative assessment, because babies will not tell you anything. So you have to communicate with the mother or father. You have to ask about the developmental delays or development landmarks. You have to ask about any other disease than the presenting complaint or the thing for which the patient is coming. If there is any congenital anomaly, you have to rule out any other congenital anomalies. Okay, these are I'm telling you the basic things. And then you have to ask about the NPO status. You have to discuss about the overall, like if the baby is not taking the feed, this is a big sign in a pediatric age group. Okay, in young babies who are on mother feed or exclusively on bottle feed or things like that. So that age group, if the babies are not taking the milk, this is a big sign. Okay, that baby is not well. Similarly, these are the things related to. Then you will discuss about anxiolysis, because we have to there will be stranger anxiety. So you have to, maybe IV lines will be difficult. These are we have discussed in last session. So I'm just repeating it, just summarizing whatever we have discussed. So we discussed that there will be problem related to airway. We have to use specialized blades, we have to calculate the LMS size or endotracheal tube size. We discuss about cuffed versus uncuffed. Okay, challenges related to blood pressure monitoring. Okay, and the parameters which are different in these age groups. And then then we move on to they are risk of respiration. They have slightly difficult intubation. We have to calculate the drug dosages accordingly. There are certain diseases or certain things which you have to look into in the babies, and then you can calculate. We can discuss everything about it. We discuss about analgesia, or did we? Or anyone who attended the first class, did we discuss analgesia in first session or no? I forget, because there is a gap of some days, so I forgot. We discussed, and I think we discussed paracetamol, NSAIDs, opioids, local infiltration, blocks, like what is the concept of multimodal analgesia? Can anyone tell? What is multimodal analgesia? What do you mean by multimodal analgesia? Using different modalities, this is one thing, okay? At different steps of pain pathway, okay? The pain pathway which you are reading in conventional books are not telling you the reality. There are 4 steps. One is transduction, like it is done by the nociceptors. The transduce, it is receiving, okay? And then it is transmitted through A delta or C fibers going towards the passing through the spinal cord to the thalamus to the brain. See, all this is transmission. This is number 2. The other step is modulation. Okay, either the pain which you are receiving will be increased or decreased or maintained through the modulation mechanism. Modulation occurs at every step. Modulation occurs for example, in neuropathic pain, even there is no pain and patient is perceiving pain. So that is the problem with the modulation mechanism. Okay, modulation is through you heard something, you hit something, and then you are rubbing it. This is modulation. You are stimulating the A beta fibers, which are closing the gate in the spinal cord, which is sending it upstairs, and you are bribing, please stop, don't send the messages to the brain. So actually, this is the mechanism of gate control theory. So similar mechanism is there with the TENS, transcutaneous electrical nerve stimulation. Similar mechanism is through acupuncture or acupressure. This is all on the gate control theory. And also there is medication, which is capsicum, which is also, it has a similar mechanism. It is relating the substance P, and it is also having effect on the gate control theory. So this is all about this modulation. So the last step is perception. Okay. So perception is in the central nervous system, how we perceive. So the medications which act on perception are paracetamol, are antidepressants, anti-epileptics. These are the things which we are using for the perception, and it has central effect. The medications like NSAIDs, it is affecting the release of inflammatory mediators. Okay, so it is decreasing the transmission as well. Okay, transduction as well. When we are giving local anesthetic, local infiltration, actually we are disturbing the transduction and transmission. We are not letting the action potential drive the pain to the forward area, toward the spinal cord. Okay, then we are using this ketamine, for example. So ketamine is NMDA receptor antagonist. It has central nervous system depressing effect as well, but it acts in the thalamus. So it is also doing the modulation. Okay. And then like opioids also act on perception. The pain is there, but you are not able to perceive it. That's why if you see the addicts, they are smiling, they don't feel any pain. They are happy. Okay, they are happy without and like they are happy. That's why people name them a number of designations. Okay. So opioids, they have effect on the central nervous system in the brain, and there are opioid receptors in the spinal cord as well, in the substantia gelatinosa. So they are also affecting in the descending. There are descending inhibitory pathways. So opioids also act on central nervous system in the brain and also act on the spinal cord, but they don't have any effect on pain actually. Anti-inflammatory medication which we are using, they are changing the response to the pain because of the release of the inflammatory mediators. That's why the concept of preemptive analgesia comes. Preemptive is you are preempting something. Okay, so you are preempting that there is going to be an injury because of surgery, and you are giving some NSAIDs before. You are giving paracetamol before. By paracetamol, you are bribing the brain. Please don't feel the pain too much. By giving anti-inflammatory, this NSAID, you are decreasing the release of anti-inflammatory medications. You are stopping the release of inflammatory mediators. Okay, so that the response of the pain before the NCN, you are giving these things. Another thing which we are using it is gabapentin or pregabalin. Not everyone will be here in pediatric age group, but I'm just telling you the overall concept of multimodal analgesia, that you are using multiple drugs in a cocktail. Okay, so you are achieving the good things by reducing their relative doses. Okay, and at the same time, you are crushing the pain at different steps. Some of the medication which I have not named at the moment, they are Dex Meditomidine, which is a alpha-1 agonist central acting, which is decreasing the sympathetic response to pain. That you are having pain, so your sympathetic system is activated, you have tachycardia, you have tachypnea, you have like high blood pressure, so sympathetic response. So this is decreasing the sympathetic response, so you are not having tachycardia or blood pressure because of pain. So this is one of them. We are using it for the control of hemodynamic response to the pain. Then we are using lidocaine. Not every one of you is familiar with use of lidocaine as IV analgesic. And actually, only people are using it to blunt the extubation or intubation reflex. But actually, lidocaine is documented. You can see in the article, if anyone wants to, doesn't find it, which majority people don't find it, it's in the article folder. Then you go to pharmacology, you will find IV lidocaine as analgesic, and usually it is given between dose of 0.5 milligram to 2 milligram per kg per hour, just like we give a bolus, but exceptions will be patient with impaired liver function. Okay, if the patient's liver is not functioning, you cannot give lidocaine because it will cause toxicity. Otherwise, you can give lidocaine throughout the procedure. Even if you don't have syringe pump, you can give by a layman by this one by the normal drip you are using. Okay, don't document it. I am just telling you a practical way that you are thinking that even if it is going very fast, it will not finish in 15 to 20 minutes. So you can put that much dose in it and it will go slowly. And then or you can have two lines, one separate for this thing, lidocaine, or there are some other medications which you can use by that way. You can use ketamine. Ketamine infusion is a wonderful medication for control of pain, giving a big giving you a wonderful control to your hemodynamic PP. But you cannot document in register in exam because in majority of the books it's not written. So you cannot document it, but practically you can use this technique. It's a wonderful technique to use ketamine. Microburette, yes, you can. I'm giving you a practical tip that if you have nothing, you can use it like that as well in a controlled way. Okay. Ideally, these medications are supposed to be given through syringe pump. Okay. Microburette, yes, you can use microburette as well, but I'm just telling you the way. And your question, Hassan, this mild analgesic, I don't know, but I have told you the mechanism of it. Okay, so now, and the regional blocks, spinal or peripheral nerve block, they are also acting by controlling transduction and transmission. Okay, and it is reducing the stress response to the pain. So that's why we say that if you are using epidural or spinal, it is blunting the sympathetic response to the pain. So that is the mechanism for it. For these are the different options, and in a patient, you can make a combination of it. Like if you have an adult, you can use gabapentin. It will have preemptive analgesia. It will have opioid sparing effect. Like you will need to give less dose of opioids if you have used pregabalin preoperatively. Similar is paracetamol. Usual majority people don't use paracetamol in the preoperative time. They are only being tuned that they have to give it for postoperative pain. But why not to use it? The concept of WHO step ladder for pain control in acute setting is to start with the maximum and come down. So if you have a fight with someone, if you slap very lightly, he will slap you very hard and you will fall down. So that is the concept of acute pain management, that you have to slap it so hard that the pain does not stand up. That's the concept. If you the first punch is more important. If you are not able to control the pain in acute setting, then patient will have tendency to go in postoperative chronic pain. Okay, so you have to control it in the maximum possible way. So preemptive analgesia by NSAID, paracetamol, gabapentin. Then you are using intraoperatively with the opioids, or you can have local infiltration to start with. You can give some block, truncal block, like if you are doing mastectomy, you can have this serratus anterior plane block, PAX block to start with, and then they can start their surgery. The patient will have less pain. Okay. And then similarly is true for the TAB block. Similar is true for any other peripheral nerve block combined with the general anesthesia. Okay, or you can use the similar by giving spinal or epidural combined with general anesthesia. So this is the concept about it. Then the rest of the medications I've told you. Pregabalin first dose should be given how many hours before surgery? You know, these cramming things you can read from the book. Usually it is, I think, the night before surgery. Okay, you can see I'm telling you the concept. I'm not putting very small things. I've given you the concept. You just check it out, because that's not very important. The important thing is that you understand why you are giving it. Okay, if you understand it, that you will find the answer. Practically speaking, not everyone is familiar to it, and not in every setting it is being used, but it is wherever it is used, it's a very nice way to to control it. There are some problems related to it. It can cause sedation, excessive sedation. So maybe in some people it is not a very acceptable thing because there will be excessive sedation. Okay? So you just have to consider accordingly. Okay. So we have just discussed few words about the like multimodal analgesia. So you will be using either of the technique in it. You should have a concept. In some babies, you are giving suppositories as well with the this one rectal suppository with of paracetamol or NSAIDs. Okay, and you can have any plan according to the situation you are dealing with. If you have a provision of patient control analgesia, it's an excellent modality. You can control the dose. You are not overdosing the patient. Because the concept of patient control analgesia is that if patient is sedated, patient will not take it more. Okay, this is one thing. And the gap between the initiation of the pain and actual delivery of the medication by the nurse or any healthcare provider, this is creating the problem. So you are minimizing this thing. It will cause more patient satisfaction when you are using it with patient control analgesia. Okay, and patient control analgesia, there are certain things which I will just give you a small hint about it, that you should be knowing about the total safe dose in that specific hour, number one. Number two, in certain conditions, you can have a basal rate. On top of that, you can have the other doses which the patient is receiving. Okay, there is a bolus dose and there is a lockout time. Okay, so lockout time is the time in which even if the patient is pressing, he is not getting any medication. So all these things are combined together to prepare for PCA, patient control analgesia. And another thing is that when you are evaluating a patient on PCA, you will be looking at the number of attempts. If, for example, you have set a dose and you have make a lockout time, and your patient is pressing too much, so you have to rethink about the dose you are giving according to the condition, or you may be adjusting it accordingly. You can increase the safe limit, you can decrease the lockout time, or you can increase the bolus, or you can give basal infusion. So these are the things by which, and this is an individualized approach. There is no general principle for it. Main concept is a bolus dose, a baseline, a bolus dose, a baseline infusion, lockout time, and maximum safe dose. And this patient control analgesia is sometimes being used in the peripheral catheters as well as epidural. So the concept is the same. Usually there is a concept of nurse control analgesia as well. It is not in your domain at the moment, but in some condition in pediatric age group, there is also nurse control analgesia. I don't think so that you should be wasting time at the moment on it. Okay. So we will finish our discussion here and we will continue with some other thing, other aspect of the pediatric anesthesia in the next setting. We discussed almost the main points about all like the general things. Okay. So similar, now it will be very easy for us to go towards to the individual diseases. Okay, because there are certain complications which are more prone in that age group, like hypothermia. We said controlled, meticulous use of medications. Then look into the airway and cardiovascular system. And the thing which we are expecting, high vagal tone, so incidence of bradycardia, overloading, dehydration, calculation of blood volume and replacing it accordingly, use of the fluid which is appropriate, and then good analgesia. And then this one, there are certain complications which can occur at the post-operative period, like there are more chances of babies going in laryngospasm. Okay. Babies will become hypoxic very quickly, so you have to make sure about these things. So these are the basic concepts which I have given you in 2 sessions, and next session we will start some disease. Okay, any question before we finish? If you want to get the maximum benefit for this, you should be looking at the previous. I have tried to revise a number of things which we discussed in detail in the first session. And you can find like even before we discussed pediatric anesthesia multiple times. Before I used to discuss in our native language, but to make it more useful for other people as well, now we have shifted to English. But if you want to see it, you will find a number of discussions done before. And last message before I finish is that please try to understand this concept, that if you have correct concepts, then it will be easier for you to approach in any exam. If you are thinking that you will be finishing one part of exam first, and then you will change something, and then you will be going towards another part of the exam, this is absolutely wrong. So please come out of it at the earliest possible time. This is not class 5. This is not FSC that you are trying to get some notes of someone. This is insult, believe me. This is your insult that you are relying on someone else's note. You should be knowing what you are doing. This is post-graduation. This is serious business. Please respect yourself. If you are just trying to find the shortcut, there is no shortcut to glory. Okay? Yes, someone else's note can be helpful to you, but it is very dangerous. It is very dangerous, and it is not a safe thing for you. Because if that person has noted down something wrong, the same thing you will learn. And similar is the problem is one book reading, which you are very fond of. So please come out of it. Try to cover it through multiple sources. Try to look in from the internet. And the best source to study are articles. The research articles and review articles are different entity. Research articles on the basis of one research on study done at a specific place. That is not what I am telling you. I am telling you about the review articles, which are on the basis of a number of research articles, maybe hundreds or thousands of research articles. They write one review article, and that is available in the form of anesthesia tutorials or British BGA education articles. I have compiled all of them, put them in the topic wise, and it's available to everyone. If anyone wants, I share a number of times, but unfortunately, because it is imprinted in your mind like a religious belief that if you don't read a book, how can you prepare any exam? Because you are still in class 5. The mentality, this is a mentality of class 5. This is not mentality of post-graduation. But because one person is just creating this sound, nobody listens. Every senior around you is telling you the same thing. Unfortunately, majority of the supervisors, they don't have time to invest and explain in details. And unfortunately, this is a thing which is moving in a vicious cycle. So I am just doing it to pull you out of this vicious cycle. Okay. Thank you very much.